for silent reflection, and the moment starts now. Thank you very much. Colleagues, this is our maiden meeting, and for both sides of the chambers, and I truly believe that this is the beginning where we will set the foundation of cooperation and collaboration going forward, and for us to know whom we're dealing with. I'm going to allow for everybody here to introduce themselves. I'm going to start with me on my left. I'm going to go the left way. I'm Emery Boyson. I'm the chairperson of the Committee for Health and Wellness. We're going this way.
Excellent. I'm Leon van Wyk, representing the DA on this committee. Thank you.
Hi, Thomas Walters. I also represent the DA on the committee.
Good morning, everyone. I'm Benedicta van Minnen, and I also represent the DA on this committee.
Thank you.
Good morning, everyone. I'm Donita Stevens, and I'm representing the Patriotic Alliance.
Morning, Chair, MEC and HOD and colleagues. My name is Rachel van Vogel, and I'm a member of this committee.
Thank you. I'm also going to allow to the member who's online.
Greetings to all. My name is Dwayne Jacobs. I represent the National Colour Congress, and I'm a member of this committee.
Thank you, members. Minister, I'm going to give over to you and your team. Oh, okay. Okay. Yeah.
You can use these for 10 electronic versions in yourself.
Okay. Member Jacobs, we were just referring to where you are, and we wanted the impression that you might not be able to follow us or the presentations, but we've just been told that you do have the capacity with your device. You will just let us know if you're struggling, Member Jacobs, when it comes to the presentations. I take it that is noted, member. Minister, if you can introduce yourself and your team as well. Thank you.
Thank you very much, Chair, and to the Standing Committee. Delighted to be with you here this morning and on this side of the bench. The last time I was in this room was on the other side. My name is Mireille Wenger, and I'm the Provincial Minister responsible for Health and Wellness. I'll ask the HOD to make the introductions.
Thank you, Minister.
Thank you, Chairperson and committee members. I'm Keith Clutie. I'm the head of Department Health and Wellness, and two other members.
Yes, good morning, Chair and members. My name is Simon Kay, and I am responsible for corporate service support in the Department of Health and Wellness, including I'm the CFO. Sometimes.
Good morning, Chair and the members. My name is Nonhlanhla Andangosi. I'm the Chief Director Strategy in the Department of Health and Wellness. Thank you.
Thank you very much to everybody. Members, just for the record, the Minister have to leave at 11 o'clock, but I've promised the Minister that by 11 o'clock we will be done. I know this is a very efficient team. Minister, I know that you're new in this portfolio, but your track record speaks for itself. And I would also like to make use of this opportunity to congratulate you on what has happened in Villiersdorp, the delivery in Villiersdorp, colleagues, the new EMS center that has been opened in Villiersdorp. That again, Minister, is an indication that we are a caring government, and this department will do whatever it can to deliver to the people of the province. And to Member Jacobs, I also want to say thank you, Member, for making the time to attend the event in Villiersdorp. And to the other members, I understand that we have a lot on our plates, and you were with us in the spirit. Thank you. Colleagues, and now that we've made the introductions, Minister, I'm going to give over to you for your introductory remarks, and then we're going to go through the agenda as stipulated. Thank you. Over to you, Minister.
Thank you very much, Chair, and to the honourable members. We're very happy to kick off the new term in this way and look forward to a constructive working relationship with the Standing Committee and the Department. This morning, we will be presenting to you, in the main, the APPs of the Department, which will give you some insights into the targets we've set ourselves for the current financial year. You'll also have some insights into the strategy guiding the department, what our organogram looks like, what the legal framework is under which we operate, and where we have intentions of reviewing pieces of legislation in which the Standing Committee will be a key partner. And then we have some information on the budget, and in particular the budget constraints and the effects that this has on the department. We feel it's important to be frank with the committee in sharing what some of these challenges are. So we look forward to engaging with you and receiving your questions. And on that note, I'll hand over to Dr. Kluti to take us through the presentation. Thank you.
Thank you, Minister. Over to you, Dr. Kluti.
Thank you, Chairperson. Thank you, Minister. So as the Minister indicated to you, the bulk of this presentation is to navigate you very quickly through the document that was tabled in Parliament. So Simon, just hold it up. We'll make an assumption that each one of you have got copies of that. So we'll make sure that you have a copy and that you have the budget, because that's quite important. So what this is just to navigate you through what the key issues is of this. So the structure of the APP, it starts with an executive authority statement. It was the then Minister Mbombo statement that's in that document. Myself statement is followed in there. The part A, and I'm just taking the parts because as you navigate this document, just to point out the overarching frame and why the document is structured the way it is. Part A is about legislative policy, strategies, and court rulings that guides what we do. Part B is our strategic focus. So it talks about the vision, the mission, the values, what the current situation is, what our external environment, what our internal environment looks like. So that part C refers to what it is we actually do. And you will see that the convention that we have functioned within is something called programs. These programs are laid down by it's a national sector determination. So you'll see it will say program 1 to program 8. In the committee, you will become familiar, Member Benvogel is very familiar with program 1 to 8 because he's been on this committee for a while, but you'll become familiar with what lives in those 8 programs, sorry. And each one has got outcomes, outputs, some targets, some planned performance, and some resource constraints or considerations that plays itself out. There's some risks and mitigations. Then there's always a big part of this document is the infrastructure projects. There's also a list of all of them. And then if and where we go into meaningful public-private partnerships, it starts appearing in this document. The part D is a very technical part. It is the technical indicator descriptions for each of the indicators that's in. And you'll see in health and wellness and the structure that we got, there is a multitude of indicators, which comes from a sectoral, from the sector. And E is the annexures that speaks to all of that. So lifting out the request from the committee. So to start off with, what is our vision and mission? So in the document, you'll find these. It's access to person-centered quality care. Because this is the last year of a 5-year cycle, we're about to go into a new 5-year cycle. So each of these things will shift. So the next time we speak to you about the next APP, it's likely to have been adapted. Second one is our mission is we undertake to provide equitable access to quality health services in partnership with relevant stakeholders within a balanced and well-managed health system to the people of the Western Cape and beyond. So that mission has also come from previous articulations. And if you read something called Healthcare 2030, which I'll come to, you understand where that mission comes from. Then the values, it is the values of Western Cape government. But as a health sector, we have added a second R. So if you read the Western Cape government values, there's one R, and that's responsiveness. We've added respect to this. So it's all the way from innovation, caring, competence, accountability, integrity, responsiveness, and health as added respect. The organogram, sorry about that, it's a little bit small. And also some of the photos are not quite there. So when you see it again the next time, all the photos will be there. So just because there's not a photo doesn't mean the post is not filled. So you'll see myself and Minister Wenger. Basically, the structure of the organization and previous members, Member Wenvogel will remember, we went through an organizational restructuring and a redesign. And what you're seeing here is probably the leanest, well, it is the leanest head office structure for a health department in the country. So what you have is 3 broad streams reporting to me. The Director of Communication reports directly to me, that's Ms. Champion. But you'll see here, Mr. K is for Head of Corporate Services, and you'll see the 4, to the right-hand side, the 4 units that's under Corporate Services, which is infrastructure, supply chain, finance, and people management. And if you look to the middle, you'll see Ms. Nkosi, she's the Chief Director for Strategy. So you'll have 4 directorates under her. The person to the left is Dr. Karim. He couldn't be here today. So he's got all the service managers reporting to him. So that's all the way from Dr. Phillips for Rural, Dr. Perez for Metro, and then Dr. De Vries, the new CEO for Grootskeur, Dr. Nkosi, the CEO for Tygerberg, Dr. Parbu, the CEO for Red Cross Hospital, and then Ms. Arendse, that's the head of emergency and clinical support services. The main services that we do is the population is 7.4 million, according to the Census 22, and 75% is estimated to be uninsured. So it's an estimation of how many people are dependent on the public sector. And fulfilling our constitutional mandate to progressively give healthcare, we then provide a provincial healthcare service to all the people of the Western Cape. So we make the point that it's to everyone. And this is preventive, promotive, curative, rehabilitative, and palliative care. And we currently do it at 564 service points. And it's a variation of service points. The outlook for the coming year, centering the expanded program for immunization is a provincial priority as part of our primary prevention strategy. And one of the things that you pick up in the documents when you read it is immunization coverage has sagged or reduced post-COVID. And there's a few factors for that, but mainly is vaccine hesitancy. And it's a very determined strategy from our side to increase the uptake for immunization around small children, because the other thing that you pick up post-COVID is that there's a risk for more and more outbreaks. And there's international outbreaks, so we've made this a cornerstone of what it is we want to do, is to protect the population and it protects the children. And community-oriented primary care then is the bedrock of what we want to do, and prevention is quite crucial for that. And also population outreach, intersectoral collaboration, and community engagement. So it does help us to work with other sectors as well in community settings. And obviously our synergies is between this health system response to something like mental health burden, eliminating TB, violence prevention, and this community-oriented primary care approach. And you'll pick up when we talk about this, therefore, one of our core pillars is something called area-based teams. And area-based teams then makes it very important that we are located in local geographic areas to respond to the local geographic needs of where people find themselves. And therefore, we work with the residents, or the intention is to work with the residents and communities, and a whole of society approach so that we can become people-centered, trusted, and equitable. We do not underestimate the level of community mistrust there is, and that we have to deal with a lot of relationship building and trust building with our communities in each pocket in this province. So our strategies and plans, Healthcare 2030 is the primary strategy. Again, you'll see from the name, 2030, it means the next 5-year plan that we're building on is the last 5 years of the strategy. But in this 5-year term, at some point, we'll come back to you to say we're talking about 2050. But the next 5-year plan is the last 5 years of this. And probably in 2 or 3 years' times, you'll see us surfacing in our engagement with you to start talking about what do we need to do for 2050. But in 2030, we're basically talking about reducing infectious diseases like HIV and TB. It was a massive burden in 2012. We are making strides, but we're still not where we want to be with HIV and TB. The second thing is improving healthy lifestyles. And it is something that we've known and can see now. The more we have to invest is improving healthy lifestyles. I mean, there's a situation now which unfortunately has affected many people that have chronic disease of lifestyle in this province, because we have a big burden of diabetes in this province. So internationally, the company just decides we're going to stop making pens. Now, everybody that's on diabetes care from us now needs to change over from a pen to a needle. And it just shows you the point that if we can work much harder on healthy lifestyles, actually, we probably can pick up more diabetes, have many people more respect to health, lifestyle choices, eating well, and fewer people being dependent on insulin. But the point is now we're sitting now, we have to run around with a whole lot of people being trained because we have this big burden of diabetes. And it doesn't take one generation to deal with it. So it's actually about the next generation and how many more diabetics are we going to create. So that for us, number two, has become much more important as Healthcare 2030. The next big thing is injuries and violence. And it's to the point where we now have a violence prevention unit in our department, but very much working with other sectors. Health cannot stop injuries and violence. What health can do is they can say, here's the data and this is where the problem is. Other sectors need to pull the levers to stop the injury and violence. Then improving maternal and child health, always a bedrock of any healthcare system. If you have healthy mothers, you have healthy children, you create the next healthy generation. So it always remains that. With a special focus on women's health and choices is a very important thing for us. And then mental health has emerged over the last 5 years as a big burden, especially after COVID. Mental health is a massive burden and we have to actually deal with it. So the Healthcare 2030 5 strategic objectives, focus areas, were actually quite astutely chosen in 2014 when it was actually tabled. An impact statement is that the PSP impact statement. So now I'm just locating you into locating all of this down into what the new PSP will be, the provincial strategic plan for the next 5 years. So that will be ensuring a meaningful and dignified life for the residents of the province. Sorry, I'm referring to the PSP statement of the last 5 years, not the new one, the last 5 years. So, and the health impact statement is that in 2025, Western Cape residents will live in longer and healthier life than they did in 2019. And we can actually come back when we do the 5-year review to say that the life expectancy has increased in this province. One of the big reasons why the, that measure is just out of my head now. Under the global measure about where health and life expectancy and education is a big contributor. The Human Development Index. So one of the big things, if you read the Human Development Index in the Western Cape, has increased over the last 5 years. The big contributor to Human Development Index increasing is that the life expectancy has increased despite COVID. The strategic plan, therefore, and you must remember that this APP is guided by the strategic plan that was signed off 5 years ago. And this is the last year of that 5-year plan. That 5-year plan, which was from 20 to 25, had the following outcomes. There were 4 outcomes. It's a health system by design that supports wellness, as you can see. It is one where children was a focus on so that they can flourish. And next one is where people with long-term conditions are managed well. And the last one was a high-performance provincial health system for the people. So it's making sure that as a system we function well. And you can then see with those high-come outcomes, we link those to specific. So when you come into the APP, you'll see that these outcome statements are linked to specific targets in the APP to pull it through. And just to give you a sense of what we mapped at the time. So when we took those 4 things, we could map it to maternal, neonatal, and child and infant mortality. We could map it to morbidity for HIV and TB, to non-communicable diseases on this one. On provincial health system, it's about coordinating everything that we need to do and do it well. And a high-performance health system for the people was about leadership, contingent liabilities, quality of the health services, effective information system, infrastructure maintained and backlog reduced, and also improve financial management. So you will also notice when you then do see our annual reports, the annual reports reflect these over a period of time. So just to talk about the outcomes and outputs then, the impact is 2025. This is like a summary. The first outcome, provincial health system, that is by design working well. You can then see the APP output that we then link to that one was redesigning our services to be more custom fit to the needs of people. The second one is children and they flourish, as they're healthy and flourish. You'll see a big output on women and children. For children to flourish, women have to flourish. And you will then see a big focus on women and children. The third one is people with long-term conditions are we're living well. So you can see our focus on HIV and TB and mental health services coming through under that. And then the last one, a high-performance system, is a technically efficient provincial health system, accessible health services, and a capable workforce. So this is just to give you the connection of what you find in the APP to the strategic plan and to show you that there's alignment between all of those. The outcomes, therefore, in this, if I take the outcomes of these 5 things, where service redesign was the first one, it was really about making sure that we integrate the need and the continuity of care so that we can work well and respond to people well. So this is about, because everybody has a range of illnesses, it is not a programmatic approach. So then if you come with something that falls outside the program, all of a sudden you are not looked after. We design the system to deal with all healthcare needs and not only a system to deal on priorities. So I think it's quite important to understand that. But so we don't have a TB service, a child health service. We have a health service that can cater to all needs in all the places people live, but we are able to put a focus on the priorities. So that's the whole idea of this. And it is reorientated around people's needs and their expectations, and we are relevant to when a person comes to us as a healthcare system. So that's what we mean by redesign. Redesign to meet people's needs. The second one, which is the children, as I said to you, a little bit here under this was that under 5, we want less children to die, but we already have a low under 5 mortality. The idea is not just okay not to die. The child also needs to thrive. And besides the child needs to thrive, they must be so well that they can actually be transforming the next generation. So it's not just not dying. So we call it survive, thrive, transform. The idea is to move out of, if we prevented as many people as dying, children dying, the next thing is you want them to thrive. And I'll come back to that. They can't really thrive if they're malnourished and they're not looked after and they're not safe. That's why thriving becomes important. They can't really transform society unless they're given an absolute wonderful start to life. So that is the intention of what we're working with this one. So you'll see in the next 5-year plan, it's unlikely that we will remove this. That will be quite a strong focus for us because we believe it's a strong lever. But investing in the first 1,000 days was a big start for us. And the idea of the first 1,000 days is when the mother falls pregnant, so it's the 9 months of the pregnancy and the first 2 years of the child's life is the most important time that you say you invest in the future of that child. So what we did in this last 5 years was to look after the first 1,000 days. So it's about who falls pregnant, looking after the mother during pregnancy, making sure she has a safe delivery, and at least give the child a good start for the first 2 years of life. And you will see that the big evidence in that is if you do that, you give people chances in life. You give them opportunities in life. If you don't do this well, you set inequality for the rest of that person's life. So it's a very important thing across the life course. And you see the contribution. If we do this well, the human development index of this province will go even higher because of this investment. The third one is HIV and TB. And obviously what we try to do here is not just HIV and TB, but also to look at mental health. So we looked at factors affecting people's ability in HIV and TB, but we also looked at what do we need to do beyond the person themselves to create the environment where they can be healthier from an HIV and a TB perspective. If an HIV and TB a person with HIV and TB live in poor conditions, it's very difficult for them to get good control of their lives. So it's the environment within which they find themselves. And the same would go for mental health. The fourth outcome is it's a health system that is basically it can adapt and it can transform. Now you can just imagine when we wrote this in 2019, we didn't know how much we were going to be forced and faced with needing to adapt and transform. Because immediately, about 11 months after we signed off this plan, we had COVID. And we learned by the job when we wrote this, our ability to anticipate and to cope with uncertainty, how to manage the multiple and cross-scale dynamics and things coming at us. We have now become a department that can manage the next thing that comes through the door or over the window or the horizon. It's the flexibility of saying a lot of stuff is hitting us. From the floods to the ESCOM, to the next thing, to the next thing, to the next thing. And it's about the ability to do that. And also to build legitimate institutions where people find us acceptable. We have to have technical efficiency to do what we do well. And we needed to show ethical and effective leadership. So for us, we put this down as an objective. We've had to live this for the last 3 to 4 years. The legislative framework, the minister mentioned this. There's a clear national framework that we operate within. And yeah, so I think we need to organize for the standing committee a test at the end of maybe the first 3 months. Have you read all the legislative? I'm really joking. The legislative framework is actually quite an extensive legislative framework. But the idea is all the way from choice of termination of pregnancy to National Road Traffic Act, to Occupational Disease, to Sterilization Act, and so on it goes. So you can imagine, because health and wellness cover such a broad area, it's a very, very wide piece of relevant legislation. We cannot write our APP and our plans being outside of the legislative framework. And we must be cognizant of that. And the overriding legislative framework that guides us, and we've had to come back to, is the Constitution. So we always have to kind of look where we are in this. The provincial legislation is very important. As the minister pointed out, there we will want to engage the standing committee early, and Chairperson, we're doing it with you today, early, in the first setting, to say there's things that we can do better. And the things we can do better is how we engage community structures. So you will see the regulations on nominations and appointments of members on boards and committees. We can do better. There are regulations, but through consultation, we can have amendments that makes it better for that. We've learned quite a bit of the current structures and who serves and how people serve and how they're nominated. Linked to that is the regulations for criteria for clustering primary care facilities. In terms of the Act, again, we've clustered some facilities have, new facilities have come along, other facilities have been consolidated. So we need to be agile to constantly look what's the best configuration of clustering to give the best possible community say in what happens in those areas. Again, it's not something that can be static. It's something that needs to move, and we need to find a way that we write the regulations in such a way that we can move from time to time as these things move. And then the last one, which we think is quite important, is since 2010, we've had the District Health Councils Act. But the District Health Council Act in itself is a very, very important avenue. And District Health Councils becomes very important avenue. And it is probably a good idea for us to look at how we make the effectiveness of District Health Councils through potential amendments to take it forward. The minister has asked us, rather than to come to you with piecemeal, we come with a consolidated whole system view on what are these pieces of things that could be adjusted and what's the motivation for making it more effective. The whole idea is to streamline things, to make it more effective, and to make it more easily to do what it can do, and then obviously get a wider range of input from stakeholders to make it easier for us as a healthcare system to engage, recognize community structures and representatives. The program structure is just briefly for you because the bulk of the document that you actually have takes this program structure. So all I'm describing to you is like a 101 on this program structure. So program 1 is basically the people sitting around the table. So program 1 is the head office management and the ministry. And obviously the idea is, does the ministry and the head office do what it's supposed to do? That's what program 1 is about. And the APP indicator although not the only thing about how effective we are, is the audit outcomes. So do we use the resources of the public wisely? So that's how we've done it. The second one is probably the biggest and widest spread program. It's got the biggest footprint. And you heard from what I've just said in the purpose of what we're doing. It is what is called community-based services, clinics, community health center, and district hospitals. So it's called the district health services together. So it is all the parts of what is called the district health system. This is where people live. 90% of healthcare happens in this platform. So it's not equal. You can see these programs won't be equal. This is probably the bedrock of what we want to do. And you can see from what I've explained to you, the main things we're tracking here is child health, women's health, HIV, TB indicators, because that is the population well-being that we're looking for. And you'll see area-based teams will become more important, violence prevention will become important, healthy lifestyles will become important, because that is what's living in Program 2. Program 3 is a smaller program, but a very crucial program. And that's the emergency medical services. So it's not only our ambulance network, it's also planned patient transport, right? And you'll hear the term HealthNet come through. But the idea is, how does patients move between health facilities or between where they live and to the place where they need to get the care? So that is what Program 3 is about. The big thing there is response times, is how long does it take to get somebody and wait in terms of that. The Program 4 is what is called Provincial Health Hospital Services. I'll explain why it's Provincial Hospital Services as opposed to the next program. And this is regional hospitals. So in your estimation, it would be the Paul, the Worcester, the George. In the metro, it is Somerset Hospital, Mowbray Hospital. It's those kind of hospitals. So it's the level of specialist hospital just below the big hospitals. And it's quite important for those. But in there is also TB hospitals. There's 6 TB hospitals in the province. Also psychiatric hospitals. There's 4 psychiatric hospitals in the province. A rehabilitation center. There's a specialized rehabilitation center at Lentegeur premises. And then dental hospital. We actually have a specialized dental hospital on the Tygerberg premises as well. So you'll understand that this is access to general specialist services. So we call them general specialist services. So you can imagine that Program 2, the big district platform, the first entry that they have access to specialists is the first level above this, which is this Program 4. And this is where all these ones are. So it's connecting specialized hospital services to primary care. And there's a term that is coming in there that's called transitional care. And very much in the next 5 years, you will hear more and more of this thing called transitional care. In the old parlance, people used to call it as step-down care. And if you read the document carefully, you come to 4.4 and it will say subacute care. But we are now repurposing the term to transitional care. That is in between an acute hospital and getting back home. It's getting you ready to function in society. And we will put a lot of store in transitional care in this next 5 years. Again, child health, women's health, and quality service indicators are important for this one. So Program 5 is it's probably the program with the least facilities, but with the biggest amount of money attached to it. Because Program 5 is only 3 hospitals. It's Grootske, Tygerberg, and Red Cross. And what you have in this, they do general specialist services, but they also do tertiary hospital services and even what is called quaternary hospital services. And it's not only done for this province, it's done for the country. Part of the challenge that you will pick up challenge that we have is the service at these 3 places are oversubscribed from tertiary service needs from within our province, but they also oversubscribe from tertiary service needs from outside the province. So our strategy is not to block people from outside the province to have access care here, but one of the things we've always tried to look at is what is the revenue that we could possibly get from other provinces where people were supposed to get the care. So this is something that will surface during this time. So child health, women's health, quality and service output is also important for this one. But very important, this is also our platform and our entry point for research and for training with the universities. It's not that training only happens there. So it happens to be when you see Grootske and Red Cross, the UCT Medical School will be close by. When you see Tygerberg Hospital, you see the Stellenbosch Medical School will be close by. So with that comes a whole ecosystem of what lives in the universities. And we have a very, very intertwined relationship with universities. Program 6 is called Nursing, EMS and Bursaries. We're actually very excited about this. It's probably the program with the least money. But actually, our investment in this money for the future generation of healthcare services is probably the most impactful. So if you take for money spent for impact, this is probably the most impactful investments we could make. And at the peril, we don't invest in this. And the reason why I'm saying this, I'll explain to you now. There was a whole story about nurse training in the country. This nursing college that we run is the first public sector nursing college that has been a fully accredited university. So our college is now a higher education institution. So we're actually housing a university just for nursing teaching. We are now doing very, very specialized and postgraduate programs for nurse speciality. Our intake, very interestingly, for the basic intake, we're taking quite a lot of people from the Western Cape to make sure that we get the nursing output. For the speciality, we're taking people from the Western Cape, but actually we're starting to take people from the country to start doing postgraduate nursing for the country. So it actually needs to be viewed like a university. We're even more excited about the EMS training college because the EMS college also is now registered as a higher education institution. And we're starting to train EMS practitioners, not only for this province, but for the country as well. And this is the program where we dispense bursaries from. So it's the most vulnerable person with the least means that has got the highest aptitude and willingness to serve as a health professional in a healthcare system. We have a bursary system to attract people into careers from this one. So our indicator to track here is the bursary allocations. Program 7, again, I would say it's like the architecture and the backbone of our healthcare system. In here lies the laundry, and if ever the committee will, if you will have a very good experience is visiting our laundry at Tygerberg Hospital. I promise you, you come back from that, you will say, wow. Because the best private sector laundries in this country is coming to that laundry to benchmark against that. So it is really something that we should be proud of. You also do.
It says over 1 million pieces a month.
It goes through those washing machines. So I guess one pack of laundry is not going to take 2 seconds to get through that. Okay. Engineering is under here. This is where our workshops are. This is where we do a lot of maintenance work and a lot of really innovative work. I mean, I always quote COVID for the engineering guys. We got oxygen delivered to people like you wouldn't know in this province. And our engineering guys just were there, put up the tanks and get the reticulation there. Orthotic and prosthetic center is a very important one for people with disability. It is how we make prosthesis and how we do it. It's actually also a very highly skilled endeavor, and the center is a really good center that we've done. And then the Cape Medical Depot and the warehouse. The warehouse is for supply chain. It's for non-farm issues. It's on the Tygerberg premises. The Cape Medical Depot is here behind us. But also the Cape Medical Depot is also people are coming to benchmark against our practices of how to do mass medicine procurement and mass medicine distribution. The whole vaccine program that we did in this province was via the Cape Medical Depot. And we could basically say whatever vaccines we had was at the vaccine points as we needed it for COVID, and we could sustain whatever the things we had to do. The last program is program 8. And here, this is what is called health facilities management. These are mainly the big infrastructure ticket items. So everything you see in the infrastructure line lies in program 8. And it is about new health facilities, but also maintenance and refurbishments of health facilities. And you can see the 500 and odd touch points I've talked about. You know, they have to be in upkeep, and new ones have to be replaced, and replacements have to be made. So there's a whole ecosystem that does this. Obviously, it's about suitable infrastructure, efficient management of this environment. And we have a very, very close relationship with the Department of Infrastructure that has to be our delivery agent in this regard. So one of the biggest challenges for this year and we will only concentrate on this one, is the budget. And I'm going to ask Mr. K to just navigate us through these slides. Mr. K, over to you.
Thank you. Thank you.
Before we give over to Mr. K, sorry, Mr. K. Before we give over to you, I've noticed that we have some guests in the gallery. And for the record, if they can just introduce themselves, please. Thank you and welcome, ladies. You may continue, sir.
Thank you. Mr. K.
Thank you. Thank you, HOD. Thank you, Chair. So this is the budget. Over, I guess it's showing the previous 3 or 4 years, well, previous 3 years audited outcomes, as well as the 23-24 numbers, and then critically 24-25 across to 26-27. So MTF is the medium-term expenditure framework. In the country, we budget over 3 years. And you will see that our budget sits at 30.5 billion rand, which is 2.21% up of what we got last year. And to say that inflation is running at a significantly higher amount, you're going to see in the rest of the presentation the impact that that has had on the organization. So moving along into the budget assumptions, it doesn't make very pleasant reading, but the reality is our compensation, the improvement of service, ICS, we got 78% of what we required last year. And so that caused us to have to reduce our CIE by 2.73%. And that is a warm body cut that we've had to. The real pressures are now coming up in goods and services, transfers and capital, because we placed a 0% inflator on those 4 items. And CPI runs at 4.9% for last year or into this year. And the National Treasury runs medical aid inflation at CPI plus 4%. So, we are having to find some very significant efficiencies, and the impact is significant on our service offering. So what did that all mean? So we did this slide just to understand what our base impact was going to be. And we started off this year with a deficit of 807 million rand. And that was simply by applying the inflators to our actual expenditure and comparing that with the budget that had been allocated to us. And that's where we started off. We had 240 million rands worth of pressure in compensation, and we had 600 million rand in goods and services. And because capital and transfers are zero-based budgets, it's a lot simpler to stop and start things in those particular spaces. But that gave us 807 million rand as a baseline reduction. So clearly we weren't able, and we shouldn't be sitting on our hands. So we have we developed this last year, and we've been vigorously applying it in terms of a framework for fiscal consolidation. So there really are 5 elements, and it's not an or situation. It's and. So it's a combination of various interventions. So we look at efficiency targets around cost containment down to the lowest level. We look at how we can get transversal efficiency gains, service redesign. The simple fact of the matter is what we funded for now is not what we were funded for previously, and therefore the service offering, the service package, and how we render the service needs to change. Policy enablement is very important beyond sector. A lot that impacts health isn't generated in the health system. And so it's quite important that we have a policy enabling environment. Credible monitoring, we need to look at this and understand really as live as possible what is happening in the system. And Dr. Kluti indicated we've got over 500 service points. It's not a small undertaking. 30.5 billion rand 32,500 people that are employed within the department. It's a massive operation. And then governance, our ability to make decisions, the correct decisions at the correct place. So some strategic decisions need to be taken at a top executive level, but we prefer to have administration and managerial decisions made as close to the ground as possible. We run a decentralized management control system. So managing the budget is kind of the combination, as I said. So they're trying to manage the shortfall. Obviously, there are two ways to do that: get more money from somewhere and reduce costs somewhere else. And so in terms of being able to find funding from other sources, we obviously have been heavily lobbying the treasuries for additional resource allocations into the health sector. Donors, in fact, there are a large number of donors in the market at the moment. I was yesterday receiving 30 million rand worth of vehicles that have been donated to us, mobile clinics. So there is a lot of goodwill and trust in the system that when money or assets are given to us, we use those in the best interests of health outcomes. And there are a number of others. So the Red Cross Trust is incredible in terms of building additional infrastructure at Red Cross. And in fact, they've gone beyond Red Cross now. They're doing some burns work in Worcester. So really just being able to leverage those opportunities. Cost sharing with partners. There's a lot of work that we do with the private sector. So we provide immunization, we provide family planning. So we provide the good, and then the private pharmacies provide the service as part of their CSI. And we've got something like 1,200 contracts that we have, about 400 active contracts across the depth and the breadth of the province, as one example of cost sharings, as well as with the universities. There's quite a lot of cost sharing that happens between ourselves and the universities with joint staff that we pay for some for, the universities pay for some for. They bring things like supernumerary. So these are the registrars, the specialists that are training at the universities who benefit our platform. I can see my boss wants to come.
But just to say a very practical example of this cost sharing is that a orthopedic surgeon that works at Somerset Hospital presented to us about maybe 5 weeks ago, that people that live now in Saldanha, that comes to Vredenburg Hospital, can get their hip operations, can get what they normally would have had to wait to get to Somerset in Vredenburg Hospital, recover, go home the next day. And that's all done on the basis that a group of private anaesthetists gives their time free of charge. They come in, do it, and that's it. So those are it's just one example, but it's a real good practical example of how cost sharing and working together with the private sector can give benefit for the patients that otherwise would have waited for that service at Somerset Hospital. Minister, we would still want to I think it's a good example to illustrate. Thanks, Simon.
Thank you, HOD. I mean, I think I think one of our major focuses now is to look beyond these numbers, and we have to look beyond the 30.5 billion rand to be able to render the service that we're required to do. And then revenue is we collect around about 500 million rand already. We should be collecting more. It's my humble opinion. And we have had some. I think there's been some intergovernmental debt challenges, which we're trying to work through, but also our ability to change the rates that we are able to change. We are allowed to charge rates in terms of universal UPFS, uniform fee something structure, program structure, patient fee structure. Yes. Structure, yes. But that doesn't necessarily take cognizance of the actual cost going into the service. And obviously, at places like Red Cross and at Tygerberg and at Grooteskiel, there's specialized services that are going in there. And because they are best in class, there are people that are covered on medical aid. Likewise, primary healthcare visits are covered under prescribed minimum benefits, and we are unlocking that potential where people who are on medical aids are presenting at the primary healthcare and getting a free service when actually they are funded for that service. So it's a behind the scenes transaction in order for us to free up some of that revenue. So there is definitely a lot of potential in that. And then I guess the one that we do focus on is around cost savings. So we've got to do rational medicine prescriptions, and it's actually incredible when we talk about cost savings. We're not prescriptive and how facilities must change costs. We just ask them to save costs. And there's an enormous amount of innovation and ingenuity that gets applied at a localized level to be able to come in with their budgets. And we've seen incredible gains that have come out of this by just allowing people the freedom to relook at the systems and say, how do we maximize what we've got? Service prioritization implications and service redesign. Yeah, I mean, in order to fit within the envelope that we've got, we have to look at how we render our services and what we can render. And unfortunately, there's a reality of there's certain things that we probably aren't going to be able to continue to render because of the resourcing. So that's our management of the shortfall, and then the resource strategy. So there really are three big areas around big questions that we're asking ourselves around how do we get the resources. So where do we get more resourcing from? So allocations from National Treasury, Provincial Treasury, alternative financing mechanisms that are potentially available to us, such as the BFI. We got some good news from National Treasury that we submitted another BFI application for the Tygerberg PPP health technology, which is in a number of years' time, is around about 2.5 billion rand, and there's been positive reaction to us. So there are other avenues in the infrastructure realms for us to be looking for additional funding. And then I've touched on the revenue. I believe we can leverage revenue. I think there is quite a lot of potential in the revenue space. And then as the pooling of resources, becomes very important from an efficiency perspective. So in other words, clinicians are able to move across the system instead of moving the patient, and so we are able to provide the same level of care, but at a lower cost, and we're able to gain efficiencies out of the pooling of staff and resources across multiple ecosystems. I think this is a big lever for us, and I think there is a lot that we can do in this particular space. In fact, the clinicians are saying to us, just let us free, and we will self-arrange and self-organize to be able to manage complex cases. And then sharing resources across social partners. I think I have touched briefly on this already, but there are a number of opportunities for us to be able to share resources. And then critically, how do we distribute resources? So when you have a limited, anytime you have something that is limited, you need to prioritize. So how do we make sure that we are funding what our priorities are? But equally, how do you make sure that there's equity in resourcing? So those communities that are more marginalized should be benefiting from a greater allocation of resourcing. And we've developed some models internally within the organization that take matters of equity into account when we are allocating funds into geographical areas. We can do it. We're doing it at a sub-district. We can actually do it at a facility level. And there's a lot of work that we've done in that space around distribution. So some of the immediate priorities, the things that we have been doing, and the managing compensation has been a real it's been traumatic. Let me just say that it has been traumatic. To the extent that we've had to close 950 odd posts across the entire depth and breadth of the organization so that we can come within the budget that has been allocated to us. And I'm afraid that's caused a lot of trauma, but in the same breath, it's actually been viewed as a wonderful opportunity to start afresh and refocus on what we've got in front of us. Our contract management, renegotiating contracts, looking at how we can realize value for money. When people come and say we're going to give you this increase, we turn around and say, let's have another conversation about what you think you are or you aren't going to put through and come up with a better thing, because we have an economy of scale. Because of the size of us, and we do a lot of transversal contracting within the province, we actually can dictate terms a little bit better than other people. Reducing wastage in the system, and there is a lot that we are doing in this particular space. I've spoken about revenue enhancement. I've touched on the alternative financing and the BFI, and the flavor of the month is blended financing opportunities. Conditional grants, there is a lot that we're doing within the conditional grant space in terms of grant equity and the optimization. There are direct grants, which we get as a province. There are indirect grants, and the reality is a lot of those allocation methodologies haven't changed for quite a while in terms of conditional grants. Donor funding. So there is a lot of work there is a lot of donor money in the system, whether that comes from USAID or the Global Fund or various other NGOs. There is a substantial amount of money, and we are gaining visibility of this money. And as in our stewardship role, we're able to now start to send those resources in the right direction. We get a much broader view, and then Keith gave an example of cost sharing, which I've spoken to. So I think the challenges, Keith, you want me to carry on, or you want us to carry on? Thank you very much. Thank you, Chair.
You got the financial picture, and you see what our current strategy are. The challenge, if that was a zero-sum game, we could balance those things like that. The biggest challenge we have is health service need is getting more. So it's not as if the health service need stays the same. So the impact of trauma, for instance, is a huge thing. So we have an incremental increase of trauma. And trauma is weekend trauma, is month-end weekend trauma. And those numbers are going up. So for us, it is very important, because if you go to emergency centers, and I always say this, which is a bad thing to say, but if you're about to get a heart attack or you have a medical complaint, the worst time to have it is over a weekend or on a Sunday night. Because that is just where you are coming into a place, and it looks like a war zone in certain of our emergency centers where somebody comes. If you come on a Wednesday morning, 11 o'clock, it will not look the same. But that is the temporal nature of what it is we're dealing with. That happens to be also the time when most people want an ambulance. So you can almost see an escalation of dissatisfaction or expectation not being met, very much with a thing that's being made from outside our system. And what we are set up to do is then to try and deal with this, what I would call, we always call it that this has become a predictable, unpredictable. It's something that's from external to us, but it's predictable. The second one is, which is really something that we felt we really want to make hope and give hope for people, both for patients and for clinicians, is that they have a sizable thing that they can work to and they can see progress. And that was the impact we had on elective surgeries. Now, elective surgery is when somebody's booked to have a surgery. It's not an emergency surgery. You wait for your date. So the moment you get a date, there's already hope for the family and that person. The last thing you want is to get there day before order day, and then your operation has to be cancelled and rescheduled because some other emergency has overtaken the system at that time. So it dashes hope, but it also gives the healthcare workers a sense of despondency. It's like they can't get ahead because the next time you just postpone a surgery, it's not as if the elective surgery stay, because a new patient is added to the list. And then all the progress you've made over a long period of time slowly starts whittling away again. So it's really this thing, the second one for me is about hope, and it's really something that's really disheartening for people working in the healthcare system. The last one is the acute hospital bed pressures. And again, that varies, but actually it's been a phenomenon in the Western Cape for a while. It's now getting a little bit worse. Is hospitals generally are full. Public hospital beds are full. And people therefore have to be discharged slightly earlier than they normally would have been discharged. And other people are waiting to get into a bed. So the pressure on the acute hospital bed is then kind of running through all of this. So these three things kind of they interchange. And that gives you a sense of what our current health service challenges are. Our expenditure patterns, and Mr. K spoke on this, right? So maybe, Mr. K, you can maybe just touch on this one.
So Chair, I'm being a little bit naughty, because this is the results, the audited outcomes of the previous year, and it shows a pattern that it now carries through into this year. So if you look carefully, you will see that we had a variance of 92 million rand. So that means we had a saving in our budget of 92 million, which is less than a day in terms of cash flow. But within that, the detail becomes quite important. So because I said we were having to start to look to cut posts because we didn't have the money coming through into this year because of the ICS reduction that we all experienced, we were holding back appointments last year. So you will see that there's an under expenditure in compensation. But I said we were going to have a goods and service pressure. And if you look, we overspent by 104 million rand on goods and services. We've also got issues in our machinery and equipment, which is to do with our GMT. So our fleet is traveling, it's getting more expensive. We're not being funded adequately for that. So this is where we came out last year, because we are not allowed to overspend. In fact, there are a whole lot of rules. There are some complicated rules around shifts environments, which say how you can and cannot offset certain savings within programs and between economic classifications. So we do this to avoid unauthorized expenditure. This 92 million rand is available to us in this year to start offsetting some of that pressure that we have. So our provincial treasury allows us to take savings from a previous year and allows us to bank those and offset those when we need them against pressures in future years. And that encourages us and encourages all departments here not to get into super spikes and spending money for the sake of spending money in order to expend their budget. We spend money genuinely to this place. That said, one of the key elements to understand where your real pressures are accruals and payables, because accruals and payables are services that you have incurred prior to the year end, but for which you can only pay the following year. And you will see that our accruals and payables have risen from 589 million to 655 million rand year on year. We are still within the margin and comfortably within the margin of paying our creditors within 30 days. You will see there are some amounts that are in more than 30 days. There are reasons for those things. But what I'm showing here is the building of the pressure in the goods and services, because we have an over expenditure in the goods and services last year. We've had an a growth in our accruals, and we've had a 0% inflation increase into this year on goods and services. And those are recurrent expenditures. And so that really is what this is. But when we come to account as part of the annual report, this is where we will talk around the impact of these things and how we navigate this going forward. So then to go to the vote expenditure for Q1. So this now takes us up to the end of June. And as I said, no surprises over here, but we are under pressure in district health services. So Dr. Kluti spoke about our big engine rooms. Out of 30 billion rand, you can see that 13.9 billion rand sits in district health services, and our central hospitals are 8.2 billion rand, and our provincial hospital services are 4.9 billion rand. So that really is the engine room of our organization. And the reality is we have very little control over who comes into our service. So we have very little control over the demand for the service. And that's a large component of our budget. So what if we then go to the next one now? We arrange our reporting in differently to the programmatic structure. So we look at service as well as geographical area in terms of our managerial reporting and accountability framework. And so you'll see when we here talk about sectors. So sectors don't necessarily marry with programs. So the admin sector is primarily the head office sector. MHS is Metro Health Services. So that is all services that are rendered within the city of Cape Town. And that includes the TB hospitals, that includes the psychiatric hospitals, because they are domiciled here in Cape Town, even though they serve a broader community as a broader church. Rural health services are the other 5 districts, and they are West Coast, Winelands, we've clustered Garden Route and Central Karoo, and Overberg. Well, Overberg is separate. And included in that are the 3 rural regional hospitals, being Paul, Worcester, and George Regional Hospital. ECSS is Emergency Clinical Support Services, so that includes EMS, that includes FPS. There are a number of elements that come in there. We cluster Groote Schuur and Red Cross together as a sector, and then Tygerberg is its own sector. Those 3 we'll find those sitting in program 5, but we cluster them as sectors. And then training and FIM, which is facilities and infrastructure management. So that includes not only the hard facility management, the soft facility management, security, and a number of issues there. So just one back, and the point having there, you look at the goods and services, you can see that we are showing a pressure of 579 million rand in goods and services in this year. So it is very real, the pressures that we are having at the moment. And then I'm going to leave this to you. Thank you, HSC.
So just in conclusion, that was quite a long presentation, but in conclusion, the budget has been cut, but the demand has increased. Second point we want to make, we've had to freeze posts, and it's mainly due to the impact of being not fully funded for the wage increase and wage agreement. We've had this goods and service pressure that's growing, and we're carrying a pressure of about 900 million in the current financial year. You see the 500s there, but the 400 on top of that is that it's still a pressure that is because of posts that we have to fill. I mean, we kind of, but services are not able to cope as we speak. The inability to mobilize the necessary financial and human and other resources, it's in our risk register, but we've also registered it up to cabinet. We're registering it with you as a standing committee, because coming in, this is real for the health sector, health and wellness in the province. We need your support in your oversight role. We cannot navigate this by ourselves. We walk this journey with you, and you need to provide us with support, because we're going to everyone. We've gone to National Treasury, Provincial Treasury, to universities, to funders outside. We have the same story. You are one of those key partners that we have. The support for additional allocations so that we can exhaust all avenues potentially for revenue. As an oversight committee, we're really asking and enlisting your support in those endeavors. The second one is the support in the reviewing of provincial legislation that allows us to raise more money. There are some things that we could do if the legislation is amended to allow us to raise and retain money specifically for health and wellness. And then this intergovernmental debt recovery, some of those things will come onto your radar. And as an oversight committee, we're asking support. So we're really saying we are committed to the principles of ethics and morality, to the progressive realization within available resources. What we are saying is we are responsible for what we have. If we got more, we can do much more for the people of the Western Cape. And we thank you for that.
Thank you, Minister Dr. Klute, you and the team. Members, there we have it, the good and the bad, the mixed bag. I'm now going to open up for any questions, comments for clarity. I'm going to start with Member Van Wyk.
Yeah, I think, Chair, I would like to thank the team for the review that they've given us, and I think it's an extremely valuable review in terms of the hard facts and the hard realities that we have within the sector, and I think that's what we have to face up to. And I suppose I wish to thank the department already for the work that has been undertaken to try and navigate through this very difficult situation. But clearly, we're going to need a little bit more than that because, and I think as a committee, we're going to have to assist you and certainly see what can be done and what other avenues can be explored to try and resolve these issues that we have. And I suppose if I go back to my municipal experience, when I saw we were not going to come out, I said, well, it's like calling Houston. We have a problem, and calling National Treasury and saying, National Treasury, something's going to blow in the system, and I guess that's what we need to do on the one side. But I think there's a lot of excellent work that's been done in terms of your innovations and your safety and so forth. And maybe we need to document perhaps that a little bit. I don't know to what extent we can document it a little bit better and say, look, this is where we have improved. That in a sense then can also work towards what I'm calling a prospectus. In a sense, how do we go with a hat to whoever else can help? And obviously, those donor type of bodies, I think, are the one from an international point of view. But then we also need to probably put elements of numbers to it. And I'm hoping that, call it a 25 million euro, is much easier to absorb on another hemisphere than 500 million in the South African context. So I suppose there's something there that we need to try and do. And I think also this whole working with the private sector in terms of that private partnership area and what one can do there and how one in effect tries to redeploy CSI in a better way. And I know some people say there's possibly not that much CSI, but I think there is goodwill. And if we approach it correctly and say we're sitting with a predicament, maybe over the next 3 to 5 years, but then we also at the national government level, we actually need that discussion needs to take place because we're not going to fix the national budget in 1 year. To me, I'm plucking a number. Being 5 years is probably, it's going to take a considerable period of time to turn the ship around. And I think the more honest one becomes, probably the better chance we have. I must say I'm extremely concerned that that there are posts that we can't fill, and how we're going to get ourselves into that level of predicament. Because I think the numbers that I'm just seeing here, and I probably need to absorb a little bit better in terms of this financial year, I don't think things are looking that rosy. So therefore we've also got to try and say to ourselves, what are we going to do to get through the rest of this financial year? And the sooner we do that, the better chance we possibly have of trying to fix it. So, so to me, I think it's probably more important that we look at the macro issues right now than because those are the big ones we need to fix. Thanks, Chair.
Thank you, Member Van Wyk. Member Walters.
Yeah, let me first start by saying this is one of the better presentations that I've seen. It's actually quite clear what your indicators are. It's not difficult to follow. I think it makes it easy to tap into playing a role here. There's a couple of things that tickled me. One is the transversal aspects of what you were referring to. So which will also relate to, call it your cost savings and repurposing of in a new fiscal environment. So yeah, for example, I think the old example that we're certainly familiar with is law enforcement around drunk driving, helping with the costs of health. Now similarly, something that occurred to me in a different committee. If one can get a demographic breakdown of that weekend trauma, I think the drunken driving one, everyone is fairly familiar with, but it would be interesting to link things like dropout rate, after school activities, policing around liquor outlets, things like that, to see whether there's whether some of the data there lends itself to transversal activities in other departments as well. So I think it's going to be an ongoing theme. It's not a direct question at this stage where I expect an immediate answer, but something I think your committee should explore. I'm also very concerned with what you mentioned with the accounts payable and the receivables. I mean, the previous legislature that I served, Gauteng legislature, it became a trap, absolute trap for the moment you move into that space, it starts snowballing. I think that's exactly what you are warning against. I think once you're there, it's incredibly difficult to get out. So I think in fact, I think you understated the financial difficulty, the dangers lurking that I do think we need to treat with urgency. And then Leon, member van Wyk here did cover me to a large extent, except I want to add something, maybe in the same vein to what he said there. It would be interesting to also look at the cost drivers of your suppliers. Who your suppliers are, what are the cost drivers for your suppliers? Because I suspect if you're going to look at private public partnerships and you're going to be exploring that type of relationship, at this stage I don't know much about it. We might need to look either at a national level or a provincial level, look at also at the supply end of your supply, the ability to deliver goods and services to you at a better rate. I think that's also something one should explore, which I suspect. Anyway, I can use examples here, but I can see you understand what I'm saying there. Then the other question, this is a fairly mundane one. You mentioned as one of your indicators that bursaries, bursaries for training people, That's one of your indicators there. Do you have data on your retention rate? Are you actually retaining and improving the existing staff? I'm pretty sure it would be in the documentation, but it would be interesting. I'm also interested in your training model of nurses, and are we importers, exporters in terms of skills? You also you alluded to, maybe you were hinting at that being a revenue stream as well. I would be interested to learn a bit more there. That makes sense.
Thank you, member. Any other members? Member van Minen, then I'm going to make my way up.
Thanks very much. I'm pretty much covered. There are just 2 points I'd like to ask. In terms of the transversal issues and data, the issue of fetal alcohol syndrome disorder. I know there has been a lot of talk over the years leading to low impulse control, even in cases that are relatively mild, and that's impact on violence and violence prevention. It's just a topic I'm particularly interested in. And then I try extremely hard, Chair, never to talk about my constituency or anything like that. But I just want to ask a question that I'm aware of because it occurs to a certain extent, or did used to occur to a certain extent in my constituency, which is when you have regional hospitals that also deal with mental health patients. And I know in the past there had to be a hold of, I think it was 72 hours before they were moved, and the effect that has on blocking beds, particularly in the context that sometimes after 24 hours or 48 hours, they think, oh, well, don't feel like doing this, and they leave. And then ultimately to re-enter the system, that whole thing has to reactivate, and the effect that has on regional hospitals. Thank you.
Thank you, member. Member Stevens, may go.
This is just one problem that we had in our own area. To me, there is no detailed plan for maintenance, only technical efficiency. The reason the rain falls, we have seen numerous at the day hospitals. It was flooded and citizens had no access to the hospitals due to the faulty stormwater pipes and poor maintenance all over the day hospitals, especially the one in Kraaifontein. And you know how long the people are waiting for appointments. And there was no entry into the hospital on specific days. So I just need to know what are they planning to do about that?
Thank you, member. Member Van Voorhel.
Thank you so much, Chair. Chair, allow me to welcome the presentation done by the HOD and his team. I also want to extend, actually, I think it was in March this year, during our discussion of the budget and the APP, the HOD mentioned that advised that we should brace for potential worsening conditions, including patients being accommodated on the floors and all those other problems. And I'm actually quite impressed when I look how you are managing the budget deficit. You are proactive, and that's what I like. Then secondly, Chairperson, I would like to take the opportunity to extend my heartfelt congratulations to our new MEC and welcome her to the department and the committee. I think this department faced numerous challenges, including aging infrastructures in our hospitals and delays in rebuilding, especially the GF Jooster. And I really believe, and I hope, given these substantial issues, I'm confident that the experience and academic background will be helpful in addressing these concerns in light of these challenges. I would be eager to learn about the MEC's vision for the department and a strategy for taking the issues outlined above. Then on slide 5, Chairperson, on the organogram, I think one of our colleagues or the members mentioned about the vacancies and all that. I would love to know if I would like the department to take us in confidence in terms of the first one. What are the current employment equity targets for the department, and are we successfully meeting these targets? If not, what strategies are in place to achieve them? And then if we can get these vacant positions within the department, could you provide this on how long these positions have been vacant? And the latest update on the recruitment process. Then, Chair, I think that's my last question. Amongst, on slide 6, main services and core functions, amongst the 564 service points identified by the department, Khayelitsha District Hospital stands out for me. We had the opportunity to visit the facility and engage with with its management and board some, I think it was last year. And during our visit, they highlighted several challenges, including unfunded mandates, such as accommodating patients from East River. I think the HOD will say some light on that. And taking in consideration the rapid population growth in Khayelitsha has not been matched by corresponding budget increase. And the hospital management has requested an additional 150 million to ensure optimal and effective operations. Then lastly, Chair, so I really want to hear from the MEC on that issue also. Then lastly, Chair, on slide 7, outlook for the coming year, I would like to pose the following question. Firstly, with Mpox having been declared a global health emergency, including in Africa itself, what is the current status of the Mpox outbreak, both within the province and across the country? And additionally, what measures are in place to ensure preparedness and readiness to contain its spread in the province? Thank you so much, Chair.
Thank you, members. Please allow me also to throw in a naughty one there. The Premier can't get enough of boasting about robotics, and I'm surprised that you guys didn't mention it or bragging about it. Can you just tell us what's happening in that space? You and your team, Dr. Cloete.
Thanks very much, Chair. We'll have to tag team on this, I think. So I don't know, HOD, if you want to take the first questions and then I'll finish off with those questions directly posed to me.
Yeah.
Or we could do it the other way around. Up to you.
No. Well, and just to also the context of Member Van Vogel's questions, I will also just come in. So just thank you for engaging the content and engaging the intent of what we put in front of you. Obviously, we've spent just over an hour giving you content. So, Chairperson, just to joke back at you, we didn't have enough time to boast. We needed another 3 hours. Okay, but we took an hour of traversing quite complex terrain. And thank you for the compliment of trying to pull it together in a coherent way. So just to Member Van Wyk's issues or comments, I agree with you. Thank you for that response. Like you say, calling Houston, it's a good response from the Standing Committee and Oversight Committee, as we want to do with all parties. I agree that creating a prospectus or making a case does require us to be a little bit more refined on what are we making the case for, what have we tried, what has we yielded. With this amount of money, we could leverage that. So I like the point of actually making a solid financial case in relation to that. And that is for, like as you say, for the macro issues. but also for multiple avenues of where we potentially could go. So we could make a refined case, not just say we want money. We say we want this kind of resources from this one or that, and this is a match, and this will give us the yield. So that would be quite a useful exercise for us. So thank you for pointing us in that direction. Yes, Member Walters, I really like the way that you've approached this repurposing issue. And just to answer your question quite directly, the reason why the Violence Prevention Unit is in the Health and Wellness Department is because of our data capability. So our data capability can pinpoint where demographic, age, per geographic area, where violence occurs. And because of that data capability, we can then triangulate to the potential factors in that geographic area that leads to the violence episodes. So one of the big things we do know is school dropout rate is a big correlation. Unfortunately and sadly, alcohol abuse is a big correlator. And we can also pinpoint the alcohol abuse or alcohol use. Other substances is a big correlator. And so we can go into various things. And therefore, the Violence Prevention Unit, as a minister might touch on that, is how does health monitor and, again, pinpoint to other sectors, if you did this, this would be the yield. One of the big things in what we're correlating is not just alcohol, but it's also the use of firearms and the availability of firearms. So we have the data for all of those to actually make a cogent case of what should happen elsewhere for what yield in terms of. So I really like that approach, and we can go into that, as you call it, like the upstream factors, track it. And some of it won't have a yield tomorrow. Some will have a yield in 3, 4 years or 5 years' time. But we have the ability to do that. I also like your approach to asking us that accruals from your previous experience is a big danger sign. An escalation of accruals, we know from experience from our other provinces, is once you hit it's like once the horse has gone beyond a certain point, it's bolted, you can't come back from it. And that's why you're almost saying to us, you're kind of understating the risk of this thing. It's a big red flag. So thank you for helping us to just articulate that we need to make that case a little bit more eloquently. And that's why you see where we get caught in between, because we keep an eye on accruals, we then say we cannot make the money run away. Therefore, we have to curb. So as long as we don't have resources, unfortunately, we have to curb to not let the horse bolt. We actually spoke to Michael Sachs, Farid Abdullah, that's doing some work of checking the finances across the country. And this was their big point with us. They're saying that we're the one system that can still manage the horse from bolting. And that's a very important part of the raising the Houston alarm with the macro issues. I also like the point that you say about suppliers, because it would be useful for us to say, now, we know that suppliers find themselves in a very difficult situation, but there must be big ticket items that we can go to the supplier and say, how do we work with you? Now, just one simple example from the National Health Laboratory Service. If we pay their bill, what's it, Simon, within 14 days, we get a discount of how much? 2% discount. So it's for us an incentive to pay their bill within 14 days, and they give us a discount. So but there's big suppliers that we can go and see what does this mean in terms of understanding what we potentially can do. And the bursary details, we definitely have it's a very sad reflection on societal reality, because Member Windvogel will remember when we did share that data. We have data of saying, of the people we give bursaries to, how many of them actually successfully complete their degree? And so one of the points was there is a dropout rate in the degree that people sign up for that we give the bursary to. So we have that data of what the dropout rate is. The second thing is the accommodation of that people back into our system, because once you're a bursar with us, it's our ability to absorb you into our system. The third thing is then your retention rate over a period of time. and how people go. So we have all of that information, and it is quite useful reading. And it's quite useful reading that helps us also to say, how do we pinpoint our bursary strategy? Because we can see where the bursary has been most successful. It helps us to say, this is the selection criteria. It gives us better yield. So we have a cycle of being able to track all of those. Yeah, remember from Minnan, the fetal alcohol syndrome impact is a real impact. There's a lot of research in the Western Cape. And I like your correlation between that. It's not necessarily only the proximal impact of the mother ingesting alcohol and the impact it has on the infant and the child, but it's the long-term impact of the child being a member of society, realizing their full potential, which is part of our under 5 child strategy. So part of our next part, and the Minister will speak about her priorities in response to Windvogel. One of them is to look after children that's low birth weight, and there's a correlation between low birth weight and fetal alcohol. And then when the Minister speaks to that, you will start seeing what our strategy is. But hence, even the more why our restriction on alcohol availability is such a key thing for us. So for us, we absolutely should. We really want to turn the tide against violence in this province. Number 1 is alcohol. Number 2 is firearms. The others will follow, but those are the 2 big items that you have to put your energy in relation to. So thank you for raising that specific issue. The issue of the regional hospital that you described is real. So when I say full beds and I say the ECs are busy, underplayed and overplay on those 2 items is the massive overplay of mental health, or let's call it acute psychiatric manifestations. And what it happens, it is basically somebody with disturbed behavior. So it is a disruptive person. So what happens is mental health manifests itself in 3 different ways. The one is it is disruptive behavior. The other one is people go into depressive, so it's the ones that's at risk for suicide. Unfortunately, that's the 2 ways that you can manifest. Unfortunately, if you're going to be this at the risk of suicide, you're not going to stand out that much as you are disruptive, because that's when you call the police, and the disruptive person must be removed. They get taken to a hospital at that very difficult, busy time with all the other trauma being there. That person in that mix is just the last thing you need to make the place completely unmanageable. And the Mental Health Care Act, which we also briefed the Minister on, makes it difficult for us because the Mental Health Care Act compels us in these acute hospitals with all these pressures to look after people with disturbed behavior for 72 hours. So this whole knock-on effect of that person not getting out of that hospital back onto the very busy EC and on hospital bed access is a real thing. And it's now everywhere. It's across the area. So again, our intervention in that area, alcohol again is the one, but in this case, substance abuse wider than alcohol is the key big drivers that we need to look at. And those involving those of the most disruptive people are people that come in with tip withdrawal and those kind of things. So that is a real big issue, and social development must walk this journey with us. In terms of maintenance, I think it is really fair to say that it was an interesting thing what happened at Kraaifontein, because you use Kraaifontein as an example. And because Kraaifontein has got that consolidated waiting area, it's designed for people when they come early that they don't have to sit out in the elements. And when that flash flood came, actually the flash flood went into that waiting area, and there were videos circulating. Within a space of 2 hours, it all subsided and the drainage was actually gone. So the issue is, what we've done on the back of that is 2 things. With the damage to old infrastructure from the first very heavy weather in July, we estimated and we could quantify all the damage at all our health facilities, and we put it part of a request from this province for disaster relief from the national government, and it was been submitted to the tune of about 10-12 million worth of damage at about 500 different health facilities across the province, the damage. The second thing we've done is to put in, what do we need to put in place to prevent floods causing that disruption? So that's fixing gutters, fixing this, taking this out, all of that. So we actually have quite a comprehensive set of things. But again, as you can see now, the maintenance budget is under pressure for fixing maintenance stuff. Now you adding this on top of it, which in itself then becomes a resource issue. It's not as if there's not identified, the plan is not there. It's about where do we find the range. And that balance for us, which is between preventative maintenance versus corrective maintenance or fixing things, is something that we constantly look in now. But we've identified the big ticket items of where it is. So places like Retreat, places like Lotus River, places like Kraaifontein, LCs, that's where we're looking to invest in terms of that. I think just to for Member Van Vogel, I'll start with your last questions. So the issue is, since COVID, we have been in this province monitoring all outbreaks. So we get a 2-weekly update on every single case of mpox, every single case of measles, every single case of whatever. In this province, we've not had any more cases than the 2 confirmed. 2 at the last one that we had was 2 confirmed cases. And our infectious diseases specialists, the ones that helped us with COVID, monitor and see the trends. So at this point in time, the people that is at biggest risk is people that have HIV and whose CD4 count is below 400. So they're susceptible. One of the things we're recommending is there's a good opportunity for us to go back to the HIV program, find everyone with a low CD4 count, get them back into the system, reinforce our messages to say that they need to be on ARVs to increase their resistance and immunity, because then you remove the biggest risk for people with mpox. That is the biggest group. So the big thing that's currently happening, which is where the international community is going into the same thing it goes with the COVID vaccine, is there enough vaccine internationally? And who's going to get access to it? That has just started now, and it's the same pattern repeating itself. That the likelihood of us getting vaccines in this country is we're competing now with first world countries for getting access to vaccines. But I can guarantee you our surveillance systems are in place. Our response to be able to pick up a case, our response to be able to manage it, all of those systems are in place like we would do with anything like Congo fever or typhoid or whatever. So all our systems are in place. Our preventive system, our recommendation is to go back to HIV, get people to get the immunity, and when vaccines become available, to do targeted vaccination in that group of people. But that's where we are. We have a very clear program in relation to that. The risk at this point, from where we're sitting in the Western Cape, is relatively low. Whenever the targets, and like we've done in COVID, if there's more cases in these pockets, we raise our risk rating, and we will respond identically to the way that we respond normally in our settings. In terms of the Khayelitsha question, Minister, just to give the context of what Member Van Vogel is talking about. Khayelitsha Hospital is a very interesting, let me put it this way, the Khayelitsha Hospital drainage area is an interesting case study for a new approach that we're taking in our department, which is called understanding ecosystems and how ecosystems fit together. So if you take Khayelitsha Hospital, it's part of a bigger ecosystem which is called Metro East. So it's Khayelitsha, like you've described, with a neighboring Easter River, with Helderberg and Karl Bremer, and draining to Tygerberg Hospital. So that becomes the drainage area. Now, what we found with Khayelitsha Hospital and with all the data we have, so back to Member Walter's question, all the data we have, trauma will be higher in Khayelitsha because of social conditions. Mental health will be higher in Khayelitsha because of social conditions. The child health issues will be higher because of social conditions. So in the ecosystem, a disproportionate burden comes from the area with the higher social deprivation. That is what happens with Khayelitsha. So the question that Minister, that Member Van Vogel always asks, and this quotes the management that says we need 500 million to do this thing. The context is, if Khayelitsha has to deal with what comes from Khayelitsha Hospital, drainage area, and none of the rest of the ecosystem response, you would require 500 million. The issue is you need 500 million, what's the word, across that ecosystem to mitigate, including mitigating where you need to stop the burden of disease from coming into the system. So there is with the ecosystem approach, Member Bentville, I can guarantee you, we are locating Khayelitsha as a vulnerable geographic area within a broader ecosystem. What resources needs to be at Khayelitsha Hospital specific is not necessarily the resources that you require in the whole ecosystem to respond to all the needs that comes from that area. So I just want to give you the absolute assurance that that is what our attention is. Because if you take any other ecosystem, you would do the same thing. Because do we say Atlantis is an ecosystem? Then we say we must do that in Atlantis. The logical conclusion of not doing it in an ecosystem is that every community in this province will say we need a 24-hour hospital and we need 500 beds. That's not a feasible response for a healthcare system. So that is the context. And I know it's frustrating to Member Bentvogel and to the members because those pressures continue there. But it's how those ecosystem fits together, how the mental health fits together. I mean, we're starting a 20-bed acute psychiatric unit at Khayelitsha. I promise you it's going to be filled within 2 weeks after we open it. You know, so the point is, it's not so much that, it's your question. How is the Lentegeur capacity in such a way that the pressure is taken off Khayelitsha? Because if we need to have a hospital only for psychiatric at hospital at Khayelitsha. It's not going to be a feasible way of responding to healthcare needs. It's in an interconnected way across these areas. So that's the context for the Khayelitsha question. And I think EE targets, I put this up here, Member Bentvogel, and it's on your slides a little bit small. And Mr. K will help me now. I think we're about 57. Are we 57 SMS members? We add them all up. Yeah. So let's go for Mr. K. Let's go for Mr. K's area. So if you say, and you look at this slide, I'll make it slightly bigger. There is a chief director. There's 4 chief directors on the right-hand side of the slide, but only 2 are vacant. You see vacant photos doesn't mean the post is vacant. If you look here, I'm putting my sparkcogs to it. When it says under the photo vacant, that's what's vacant. On that page that you have currently, there's only 3 vacancies or 4 vacancies. I'll run through it quickly. Mr. K, that is the director for people development, and in your area, and the second one is a vacancy for supply chain. Only 2 vacancies in the whole of corporate services. Do you want to do a quick rundown of the process for those 2? Oh, I can quickly say it. Member Bentvogel, we've already gone through 1 cycle of recruitment for both. We couldn't find appropriate candidates. So there's an issue that I'll come back to. So already advertised, and we're going to re-advertising, and we now might have to look for, what do you call that thing? Headhunting and whatever. So that is run very clear. If you go to Ms. Nkosi's line, there's 1 vacancy there. That post has been to cabinet last week. We are waiting for the person to be accepted, and we fill that post. That's for ICT. If you go to the service side, there is probably, if I look at the service side now quickly, Simon, if you could just help me with the vacancies there. Yeah. Services, there's only...
There's no vacancies, but there's about to become a vacancy in the West Coast with the district retirement of the
Dr. Walkeridge.
But that post will be, yeah.
So the point I'm making, that entire thing that you see, if you blow it up and we should give you an A3 or an A twice size, there's 3 vacancies. For all 3 of them, we have a recruitment selection process. For all intents and purposes, there is no vacancies in the senior management system of our department. That's in response to your question. And then the last issue that I just wanted to raise before I hand over to the minister is this issue about when you say the vision for the minister in relation to a lot of the things of how she's going to respond to all of this, is the issue that you make. So I missed that issue. I probably didn't write it, Minister. Sorry. I gave an overview, but over to you. Sorry.
I hope I'll.
Oh, sorry. I was just going to one last thing.
Hey, perfect.
I was a chairperson. Sorry, chairperson. I just made an offhand remark to the robotics. I think the important things of why we said, and we have just one comment somewhere: service redesign and innovation service delivery models. The robotics is one of probably 25, 30, 40 different types of innovations. I think that's the point that one of the other members made, is we need to be a little bit more explicit about those innovations, what we've tried, what the impact has been in relation to that. Thank you, Chairperson.
Thank you. If I may, just tagging on from that, I visited George Hospital earlier this week, and they have a little robot. I forget what his name is.
Yeah, he's got a name.
And what it does is, it's quite extraordinary. It links to a specialist at one of the tertiary hospitals, and this Twitter ski, and this robot is able to navigate around the patient with the doctor in the room and to be able to do a teleconsult. I mean, it's quite extraordinary. So instead of the specialist having to move geographically, we can of course see more patients using the technology. Maybe at some stage we can share more information with you, but it really is quite lovely and very useful, and having quite a lot of success. So first, thanks very much to all the members for your comments and for the support received in this presentation and understanding some of the complexity that the department is facing. In response to many of the budget-related questions, I think just overall, I think this is, I think it's the whole of society and the whole of government that will have to work together in how we solve this, because the reasons are multifaceted. So yes, there are through the formal budgeting process, but there also the macroeconomics of it. It's the fiscal emergency that South Africa still finds itself in, and so economic growth, which then leads to lower tax revenues, which then means that has an effect on the fiscus. But then there are also wonderful opportunities for partnership and how we can work together, how we can make efficiency gains and so on. So in that respect, it's a good opportunity for us to identify where we can work together to help solve these problems. On the ministerial priorities, to the honourable member that asked the question, and thank you very much for your words, just to say that as the HOD mentioned, we are developing the provincial strategic plan. So we are developing what the policy, strategy, and then the budgets to align with all of these things. We're going through that process now, and we'll be ready to launch all of it come 1 April next year, and we'll be going through those debates in the legislature probably in March. But I am willing to share with you what I'm thinking and where I'd like to put specific focus, in addition to my oversight activities over the department as a whole within each of those programs that the HOD highlighted. And there are certain broad areas that I am very interested in. As I said, it is under development and may still change, but I'm very passionate about children's well-being, and in particular malnutrition in children under 5. The HOD mentioned low birth weight babies and integrating that into our first 1,000 days program. And how can we look at ways to prevent stunting? Because we know that stunting is an underlying factor in almost 60% of child deaths in South Africa. And this is something that we need to address as society and as a health department. We also know that stunted children are less likely to finish school. Stunted children are more likely to live in poverty as adults and are 3 times more likely to have stunted children themselves. So it's about breaking those negative cycles. And so I'm doing a lot of homework on this, and this is an area I would like to put a spotlight. Then the second area is around the capital build program. Looking at ways how we can unblock and how we can speed up, and in particular about the Klipfontein and Belhar regional hospitals and how we can get those built quicker and faster, and what are those mechanisms. We're trying to understand the terrain and to see how we can do that, because ultimately once we have those infrastructure projects in place, it helps the ecosystems, and it means better provision of healthcare and access, and also means reduced waiting times, which is ultimately what we'd like to do. Given my background, I will of course put a lens on the violence prevention and how we can make communities safer because there's less violence. So here it's a real partnership, and it links in with your question, Honourable Walters, about the traffic interplay, and we'll be working with mobility as well as our colleagues in the police oversight and community safety department, because each of those have different roles to play in different spaces in time. So, for example, their roles are in the immediate term, and we have the data to help them make informed decisions. But we also have the ability to look at the longer term prevention activities that can help for the next generations to make sure that we really do everything we can to help reduce violence. And then finally, it's about expanding access to healthcare. And what do we need to do that? So in particular, it's about creating a sustainable budget for the department. I won't relitigate what was said here today, but having a sustainable budget is absolutely essential if we're going to continue to be able to provide and hopefully expand healthcare access. And then it's also about how do we partner? How do we partner with NGOs and the private sector to increase that access? So what are the different mechanisms and things that we could look into do that? So that's sort of where my mind is on the priorities for the moment. And of course, once it's set and it's gone through the various processes, I'll be sure to come back to the committee and share exactly what those ministerial priorities are over the next 5 years. Thank you.
Members, before I allow for any possible follow-ups, I'm very wary of spies. We've been joined by a gentleman. Would you please introduce yourself, sir? Thank you, sir. Members, any follow-up comments? I'll start at the top this time. Member Van Vogel.
Chair, mine is just on the violence prevention unit. Can we have a type of update on in terms of are all positions filled? And what tasks up until now was accomplished? Just so that we at least have an idea what is happening there. Thanks, Chair.
Yeah, so just to say that the violence prevention unit, we can now say to you that we have a director and a director, the actual unit, a director, 2 deputy directors, and about 2 or 3 additional staff. So it's about 6, 7 people that make up the central unit. The posts are filled. Then quite a unique thing about the violence prevention unit is we are employing people that are not in the unit. They are detached and they are within the decentralized system. They are called safety coordinators, safety promotion coordinators. We can also now say to you that we got 5 in the rural districts. So we have 1 for one for Cape Winelands, 1 for West Coast, 1 for Overberg, 1 for Garden Route, and 1 for Central Karoo. 5 appointed. They have specific towns where they will work. Like for instance, in Garden Route, it is in George, and it's focused on Thembalethu. In Central Karoo, it is in Beaufort West. In Overberg, it is for Theewaterskloof. So it is in the Theewaterskloof area. And in Cape Winelands, it's in Witzenberg with the focus. And in West Coast, it's on Swartland. So that's where the people are, 5 of them. The metro has been complicated, but we can now say to you that there's 1 person for Southern and Western with a focus on Atlantis. There's 2 people in Tygerberg Northern, both appointed. 1 obviously for and the Tygerberg Northern areas is Kraaifontein, Delft, which is a big area, and it's going to be Bishop Rivers. So the 2 people cover those 3 areas. In Klipfontein, Mitchells Plain, we got 2 people, and that's where it's in the heart of the Cape Flats. That's where the most areas are. So they cover places such as Gugulethu, Hanover Park, Mitchells Plain, and Nyanga. So that's where the 2 people are, in both appointed, very senior people, really, really hitting the ground and doing wonderful work. And the latest addition is in Khayelitsha Eastern. We've just had 2 people appointed. They started work 1st of August. Yeah. So their focus will be on Harare and on Site B and Umfuleni. That's the focus for them. So full complement, all there. The type of activities that they're doing mainly has been about building relationships. It's going out and actually getting to know everybody there. And their job is actually coordinators. They're just bringing the local efforts together in a coordinated way. And as Minister said, we are very excited about this working together to make their ability to pull people together from all aspects, from law enforcement to prevention with the social and school interventions and all of that, and urban design, which is street lights and things that municipalities done. So we're very excited. We got the architecture in place. The next thing now is to see the results in practice.
Minister, to you and your team, I can already get the sense that you can rely on the support of this committee, vice versa. And Minister, we're right on time, 11 o'clock. You and your staff are getting permission to be excused. Thank you. Members, do you want to stretch? Or, all right, we get a 10-minute stretch. Thank you, Doc.
There are refreshments outside.
Tea and coffee is served. Yeah. Not for. It's going to dry. It's quiet for a storm. But what's that? It's better seeing where they come from. It's all driven. This contextualize what you're looking at. Amongst this budget, we'll see. Ali Becher. Ali Becher of this committee.
I think Wendy was part.
You're all alone.
Huh?
You're all alone.
Very lonely.
Share and teach.
Yeah, we started there. Eh? Several of us will assist.
You said, whichever conversation with the financials now, if you, if they're going to Very much. We are back in session. And to probably kick off with, members, are there any resolutions that we want to formulate out of the presentation? Any ideas, suggestions? But what I can say is that there are a lot of opportunities within this department in terms of how the internal operations are, you know, for probably us to go and affair ourselves with it. So the draft program is going to be interesting in terms of possible visitations. Don't know what else, Namonde. Any specifics, or will we stick to the draft program so long, and then things will evolve as we go along with the program?
I would think we stick to what we've got there.
Okay.
But I think we have to be very mindful about these fiscal constraints that they have. And to me, I think there's got to be a, not that I should use the word aggressive, but certainly a very proactive approach, if I use proactive rather, to how this is going to be resolved, because we certainly can't afford for health to slip into this 500 million hole. It's quite dramatic. I mean, it might only look at 5 or 6 days worth of funding, but effect of that over these next number of months, some critical decisions. To me, you know, they say they've taken that hit in reducing staff, but that doesn't help the overall situation that we have. That to actually have staff that are not employed right now. So I think that, you know, I think we've got a program over there, but I think it's got to be fairly, you know, we're going to need to try and follow through on what they need to do and how we deal with this on the other platform other than within the committee.
Thank you, member. That is noted. Colleagues, we've already dealt with 11.B, the program. So we're going to stick to the program, and it's going to be a living document. It will change as we go along. Can we then go to the consideration of the minutes of the 4th of July? I think that is when we were constituted, if I'm not mistaken. May I have a proposal for that, for the minutes?
I'm happy to propose, Chair.
Proposed by Member van Wyk. Any seconder to that? Member Stevens. Thank you very much. Any other members, matters that we did not think of? All right, colleagues, in the absence of none, the meeting is adjourned. Member Van Vogel? Oh, sorry, we kick-started while you were outside. Yes, my apologies for that, but the agreement is, member, that we adopt the program, you know, and we will revisit the program as things unfold.
Request, Chairperson, that whenever we are going to do the oversight, it must be unannounced visit. That's my humble request, so that we can say what you see, what you get, what you see is what you get. Because my experience is when they know we are coming, things are put in place, and you know. So that's my humble request.
Are you proposing that all visitations should be unannounced?
I think it depends on where we are going,
okay.
but yeah.
All right. All right, now we'll definitely consider as we're going to get to the specific visitation points, and then we as a committee will make that decision that it's going to be unannounced or announced, and then we'll just take it from there. Amanda, any other thing?
Okay, it's just I'm not sure if now the two resolutions that have adopted or what the demographic breakdown for trauma incident. Must I still request that information from the department here? Oh, it was answered.
I was satisfied with the answer. It might be useful. I didn't suggest it as a resolution. I was actually trying to see whether it's available and what the thinking there is, which I was very satisfied with. Chair, I'm actually in your hands. I'm very happy. I would love to have the information, but it's very much for my own. For my own personal.
I'm on your side, member, that we can get it.
Data on bursary holder retention and dropouts rate. Do you need that?
Yeah, we would love to have that as well. It will give us a sense on what is happening in the department. So you'll add that, yeah.
Yes.
All right.
And
Sorry.
Stevens, yeah.
See, there's no names under the metro or the unannounced visits.
yes.
Can we add Kylie Chain Kraaifontein under that? If possible.
You mean as visitation?
Yes.
All right, Kylie Chain Kraaifontein, we'll squeeze it in.
Yes, thank you.
Chair, just members, please take note of that joint visit of the Standing Committee on Social Development and Health to the Southern Cape. The provisional dates are from the 30th of September to the 4th of October. So we are still going to request approval from the Chief Whip. If we are granted, then the members will conduct a joint visit for both committees, Health and Social Development.
The reason for that joint visit, members, is because some of us serve on both committees. So it would then be easier for us if in a specific area, then we cover both our committees that we serve on. So Namonde, we're happy with that?
Yes, Chair.
And then we'll take it from there. Members, thank you very much. Meeting is adjourned. Thank you. Oh, it goes.
Oh, we need to know. So, yes.
There's baptism.